Okay, so welcome to Acute Graft versus Host Disease 101B as part of the CTTC education series. This part of the presentation is aimed at our healthcare providers, residents, fellows, advanced care practitioners, nurses, any of our allied health team, as well as patients and their caregivers who are looking for a little bit more detail. So the objectives for this presentation are to describe the clinical manifestations and staging of acute graft versus host disease, and importantly, the distinction of acute from chronic graft versus host disease. We're going to describe the basic pathophysiology of acute graft versus host disease, describe risk factors, prophylaxis strategies, as well as initial treatment and treatment of steroid refractory disease. So in the past, as you might know, there was a fairly simple classification system for graft versus host disease. Any manifestations of graft versus host disease before day 100 were known as acute graft versus host disease, and any manifestations occurring after day 100 were called chronic graft versus host disease. And this is no longer the case. So this system is too simplistic and ignores the fact that the clinical manifestations of the graft versus host disease, which link to the underlying biology of the disease, are far more important in terms of differentiating between acute and chronic graft versus host disease. So we have a little bit more of a complicated classification system now, but here it is. So we'll describe it to you here. So the question is no longer really at what time point the patient is developing features of graft versus host disease. The important question here is, do the clinical manifestations of the graft versus host disease point towards acute or chronic graft versus host disease? The classic features of acute graft versus host disease, the maculopapular rash, the GI involvement with nausea, vomiting, or diarrhea, or anorexia, and liver disease, particularly elevated bilirubin, are common features of acute graft versus host disease, but they can occur in conjunction with features of chronic graft versus host disease as well. But to diagnose chronic graft versus host disease, one must have a diagnostic manifestation of chronic graft versus host disease as outlined by the NIH consensus criteria. And I'll take you through that really briefly. So this paper is a very good read. This is the most recent as of right now diagnosis and staging working group report for chronic graft versus host disease. So it's highly recommended reading. Will help to really expand your understanding of chronic graft versus host disease. But briefly, some of the more common examples of diagnostic manifestations of chronic graft versus host disease that are outlined in the NIH paper are cutaneous lichen planus that you see in box A at the top left here. So these are erythematous to violaceous papules or plaques with a predilection for the dorsal hands, feet, the forearms, and the trunk. And they do often have there is often some fine scale on top of the rash. You can have sclerotic manifestations that you can see here in B and C, where you're going to have tightening and thickening of the skin and subcutaneous tissues, and that could lead to joint contractures and breakdown of the skin. And in D, probably the most common diagnostic manifestation that we see is oral lichen planus. So these white linear streaks that you see here on the buccal mucosa and the lips of this patient. So if we go back to our classification system for graft versus host disease here, if the patient has one or more of the common features of acute graft versus host disease, but no diagnostic features of chronic graft versus host disease, then we are dealing with acute graft versus host disease. At that point, we can move on to look at the time post-transplant. So acute graft versus host disease can be called classic if it occurs within the first 100 days. It can also be called de novo late acute if it's occurring for the first time after day 100, recurrent late acute if it's recurring after day 100, after the initial classic acute before day 100, or it can be called persistent late acute if it started before day 100 and is persisting after day 100. But the most important thing to know here is that if you have a diagnostic manifestation of chronic graft versus host disease, even in the presence of these common features of acute graft versus host disease, that is a diagnosis of chronic graft versus host disease and not acute graft versus host disease, no matter the time post-transplant. So let's talk about the pathophysiology. This figure on the right of the slide here has been around for a long time. It's from a review that was published in The Lancet in 2009, but I think it's still very relevant to clinicians in terms of understanding how acute graft versus host disease happens. In number one, on the left side here, what's really important and in the initiation of acute graft versus host disease is damage to the recipient GI tract. And this leads to pro-inflammatory cytokines being produced. And what happens here is you get activation of the recipient antigen presenting cells. And interestingly enough, these recipient antigen presenting cells will interact with the donor T cells. And you see that down here in number 2, donor T cell activation. And these donor T cells with this inflammatory milieu will proliferate and differentiate. And then these cellular effectors, mostly T cells, but also NK cells, will accumulate in target tissues and cause apoptosis. So that's a 100-foot clinician's view of the pathophysiology of acute graft versus host disease, which in itself could be a separate presentation. So the clinical manifestations of acute graft versus host disease are well known to most people. On the skin, you tend to see a maculopapular erythema. In severe cutaneous graft versus host disease, you tend to see bullae and desquamation. In the gastrointestinal tract, patients will develop in the lower GI tract diarrhea that can be associated with hematochezia and fairly severe abdominal pain. In severe acute graft versus host disease of the lower GI tract, you can see ileus as well as very severe abdominal pain, usually requiring opiates. With upper GI involvement, patients will develop anorexia, dyspepsia, nausea, and vomiting. Again, this needs to be differentiated from toxicity related to conditioning, and thus really persistent upper GI symptoms, especially after day 30, are important in terms of thinking about acute graft versus host disease in the upper GI tract. With the liver, acute graft versus host disease tends to be a cholestatic liver disease, and so we tend to see elevated conjugated bilirubin as well as alkaline phosphatase. The liver disease almost never occurs alone. Usually this occurs in patients who already have skin and or gastrointestinal involvement. So here are some pictures. Here is a erythematous follicularly based acute graft versus host disease in the lower extremities. This can be more obvious and involve the palms and soles with these very erythematous macules in this picture. Here's a fairly typical, more extensive acute graft versus host disease with severe erythema as well as some desquamation on the back of this patient. And here, of course, is what we never like to see, which is very severe skin involvement. This patient has significant skin breakdown as well as some active bullae here on the back. And so you can imagine here that maintaining the patient's body temperature, hydration, as well as risk of infection are major concerns when you're having severe involvement in skin breakdown. So with respect to diagnosis, it's, as you know, very important to consider the differential diagnosis. We're doing a lot to patients after transplant. They're on a lot of medications. They're at very high risk of infection, and features of medication toxicity or infection can certainly overlap with signs and symptoms of acute graft versus host disease. Skin can be diagnosed based on appearance if there are really no competing diagnoses, but one must really consider drug eruptions or viral exanthems. And so getting a skin biopsy is a fairly easy intervention that can help you feel a little bit more comfortable with your diagnosis, particularly when you're thinking about having introduced new drugs or possible infections. With the GI tract and the liver, you really need histologic confirmation here, and that's because infection is quite common, particularly CMV, C. difficile, or other infections of the lower GI tract. Medications and conditioning related toxicity that is persistent can all mimic signs of acute graft versus host disease. And with the liver, there are other important differential diagnoses, veno-occlusive disease, infections, drugs, conditioning-related toxicity as well. And so getting histologic confirmation of graft versus host disease is quite important. In terms of staging and grading, each organ is going to be staged and then a global grade is assigned, and I'll show you that on a subsequent slide. The GI tract is staged by diarrhea volume. Liver is staged by the degree of bilirubin elevation with discrete cutoffs, and the skin is staged by body surface area involved. And in terms of quantifying body surface area involved, typically this is done by the rule of nines, where the head and neck is worth 9%, the chest and upper back are 9% each arm is 9%, the abdomen and lower back are 9% each, the genital area is 1%, and each leg is 18%. And it's important to know that each limb can be fractional. For example, if a patient just has upper arm involvement to the elbow, you would call that 4.5%. Or if the patient only has really anterior leg involvement, you could call that 9%. So there are a couple of different staging and grading systems for acute graft versus host disease. The one that's endured and is used at most centers is the 1994 consensus criteria, which I've pasted below for you here. So you can see here that each organ is staged from 0 to 4, and then you put these together into grading. So for example, if you're thinking about grading, an overall grade 1 acute graft versus host disease would correspond to just skin involvement at a stage 1 or 2. So if you look up here, that would be a maculopapular rash involving up to 50% of body surface area. When you have grade 2 to 4 acute graft versus host disease, this implies you either have extensive skin involvement with more than 50% body surface area, or with ulcerative or bullous dermatitis, or you have involvement of the liver or GI tract. As you can see here, even stage 1 liver and GI involvement automatically put you into overall grade 2. When it comes to grades of acute graft versus host disease, it's really grade 2 to 4 that typically requires systemic immunosuppression and has implications for treatment-related mortality. And so you will see really a focus on grade 2 to 4 acute graft versus host disease in the literature. In terms of epidemiology, it's quite difficult to provide really firm numbers. And this is because there's a huge heterogeneity in patient populations, conditioning regimens, donors, stem cell source, and graft versus host disease prophylaxis strategies center to center. And so the literature, of course, is quite heterogeneous. The graphs below show data from the CIBMTR for a reasonably large modern cohort. The graph on the left shows the cumulative incidence of grades 2 to 4 acute graft versus host disease. And you can really see, depending on the conditioning regimen and the stem cell source, that the cumulative incidence ranges from something like 30 to 50%. The graph on the right here shows the cumulative incidence of more severe grade 3 to 4 acute graft versus host disease with a range of something like 10 to 20%. These graphs I pulled were from the matched sibling part of the cohort, with the unrelated donor cohort graphs looking similar, but with these curves shifted upwards to somewhat higher cumulative incidences. In terms of risk factors, the ones here in bold are the ones that have been consistently shown across the literature. And so, of course, the most important is the degree of HLA disparity between donor and recipient. Sex mismatch, particularly a female donor to male recipient, has been fairly consistently shown to be a risk factor. The source of the graft we know is important, with peripheral blood stem cells leading to more acute graft versus host disease than bone marrow and umbilical cord stem cells. There has been some inconsistent data about the intensity of conditioning, with perhaps myeloablative conditioning with TBI resulting in a higher incidence of acute GvH, higher comorbidity index, and higher risk or more advanced disease playing into risk in some studies as well. In terms of prognosis, it's not surprising that acute graft versus host disease is a risk factor for treatment-related mortality. But the good news is that the prognosis of acute graft versus host disease has improved in recent years. And so on the right here is a CIBMTR study again, showing the cumulative incidence of treatment-related mortality for patients with acute graft versus host disease in 3 different time periods. And you can see that in sequential time periods, the cumulative incidence of treatment-related mortality is coming down. The improvements in treatment-related mortality are probably due to improvements in supportive care, such as the availability of broader spectrum antimicrobials, preemptive therapy of cytomegalovirus, and other important advances. There's also been a shift to less grade 3 to 4 acute GvH, and more patients have been shifted down to grade 2 acute graft versus host disease as compared to prior decades. And so a lower stage of acute graft versus host disease is easier to treat and tends to respond better. So in terms of prevention, this falls into 2 categories. Selecting an optimal donor, if possible, you take that with a big grain of salt, as we don't always have the luxury of selecting from amongst multiple donors for patients, and prophylaxis strategies, which are very important. In terms of selecting a donor, obviously minimizing HLA disparity is very important. When there's more than one ideal donor available, consider a male donor for a male recipient. Now, this may or may not be the most important thing when you're selecting a donor, and this tends to be really dependent on the patient's underlying disease, their comorbidities, and each center may have a slightly different donor selection algorithm. In terms of prophylaxis strategies, the most widely used would be calcineurin inhibitor plus what's called short course methotrexate. That is 4 doses of methotrexate given on days 1, 3, 6, and 11. Usually a little bit of a higher dose on day 1, typically 15 milligram per meter squared, so not huge doses, and then 3 more doses at about 10 milligram per meter squared after that. Calcineurin inhibitors are typically either cyclosporin or tacrolimus. Again, this tends to be center dependent. An alternative is a calcineurin inhibitor plus MMF, which has been studied mainly in more reduced intensity or non-myeloablative settings. We all know for haploidentical transplant, the acute graft versus host disease prophylaxis strategy needs to be more robust due to the HLA disparity. And so post-transplant cyclophosphamide, otherwise known as PT-Cy, would be the most common approach here, particularly in North America, where 50 milligram per kilogram of cyclophosphamide are given on day 3 and day 4 after transplant. Usually there is also a calcineurin inhibitor as well as MMF for the first 30 days or so. Many centers add rabbit ATG, and while we typically think of ATG as being associated with a reduced incidence of chronic graft versus host disease, several randomized trials, including this Canadian study, have shown that the addition of rabbit ATG to conditioning also reduces the incidence of acute graft versus host disease. In terms of treatment, this really depends on the grade of acute graft versus host disease that we are treating. With grade 1, again, remember that would be typically stage 1 or 2 skin involvement, so less than 50% body surface area involved with the skin without GI or liver involvement. Typically, this is treated topically, and we would typically use high potency topical corticosteroids that are applied twice a day. One example is betamethasone valerate, 0.1%. We need to use lower potency topical corticosteroids twice a day on the face, and that's because the face is more susceptible to atrophy, telangiectasia, and acneiform eruptions. So a lower potency steroid like hydrocortisone 1% would be typically used there. Usually, if these patients are still on their calcineurin inhibitor for prophylaxis, you would want to optimize the level or re-increment if that patient was on a taper of their calcineurin inhibitor. Grade 2A acute graft versus host disease, which I will define for you in a second, is a little bit of a special case. What grade 2A refers to is early involvement of the GI tract. So stage 1, specifically involvement of the GI tract. That would either be upper GI involvement or lower GI involvement with less than 1 liter of diarrhea per day. You could also, in conjunction, have stage 1 or 2 skin involvement, but specifically no liver involvement. So this combination has been recently referred to as grade 2A acute graft versus host disease. And really the reason why it's important to separate this out from other grade 2 acute graft versus host disease is that it tends to respond better to therapy. And so there have been a couple of trials. The most recent one I've pasted down here for you, looking at lower doses of prednisone plus topical therapies for the GI tract, and they tend to be quite effective. And so with grade 2A, it is reasonable to start a lower dose of prednisone, 0.5 milligram per kilogram, and topical GI therapies. And by topical GI therapies, we mean beclomethasone dipropionate for the upper GI tract. This is typically compounded into some sort of oil, so when the patient swallows it, it kind of coats the upper GI tract. And or using oral budesonide. This is a controlled release capsule that was initially made for treatment of inflammatory bowel disease, but can be a very good adjunctive therapy for graft versus host disease of the lower GI tract. For more typical grades 2 to 4 acute graft versus host disease, systemic corticosteroids are really the mainstay of treatment. Finding the right dose of corticosteroids is kind of like Goldilocks. So doses as high as 10 to 20 milligram per kilogram of corticosteroids have been tried, and doses as low as 1 milligram per kilogram as well have been tried. With high doses in that 10 to 20 per kilo range, there's been a big risk of opportunistic infections. And with low doses, a couple of studies have showed that patients eventually may need to be upgraded on their dose anyways. And so it seems like the nice place to start is something around 2 milligram per kilogram. Again, this could be center dependent, but this would be a typical dose range of either methylprednisolone or prednisone equivalent. Again, if the patient was on a taper of their calcineurin inhibitor, or if their trough level was running low, you may want to optimize their level or re-add their prophylaxis agent if it had been recently discontinued. For patients who are responding, they would usually begin a taper from these very high doses of steroids at about day 7. And you can also use the topical therapies for the skin and GI tract that I mentioned on the previous slides as add-ons. In terms of outcomes, the estimates are quite wide, but in general, about 25 to 40% of patients will achieve a complete response. You can imagine that response rates are higher for patients with grade 2 and lower for patients with grade 3 to 4 acute graft versus host disease. So what that means is you will have patients who are refractory to initial treatment with steroids, otherwise known as steroid refractory acute graft versus host disease. There are varying definitions of what steroid refractory means, but one common definition would suggest that if patients are having progression of their acute graft versus host disease by day 3 to 5 of corticosteroid initiation, or no response by day 7, they would be considered steroid refractory. This really implies that these patients need to be monitored very carefully on a daily basis if possible to really evaluate the response early on to corticosteroids. Unfortunately, with steroid refractory acute graft versus host disease, response rates have been typically low with really any second-line agent, and there is a relatively high rate of treatment-related mortality associated with this disease. The good news is that we have a relatively new option for treatment of steroid refractory acute graft versus host disease, and that's ruxolitinib. And this is on the basis of the REACH-2 trial, which was a phase 3 multi-center randomized control trial of ruxolitinib versus best available therapy, which was investigator selected and could have been a host of any other previously used therapies for steroid refractory acute graft versus host disease, things like TNF inhibitors, mycophenolate, ATG, extracorporeal photopheresis. The investigators could choose from among these, and then patients were randomized to either ruxolitinib or the investigator choice. This is a rare event, a randomized control trial in the transplant realm and in the graft versus host disease realm nonetheless. So this is a landmark trial for stem cell transplant. What the trial showed was that ruxolitinib was associated with superior overall response at day 28, at 62 versus 39% for best available therapy, with more patients achieving a complete remission at 34% versus 19%. That response rate was mostly maintained at day 56 at 40% versus 22%. And by day 56, more patients in the ruxolitinib group were off corticosteroids versus best available therapy at 21% versus 14%. Now those numbers, as they drop off there, still, give you the impression that this is a very difficult disease to treat. But at least ruxolitinib gives us a new option that we didn't have until recently. Ruxolitinib does certainly have some toxicities in terms of anemia, thrombocytopenia, as well as CMV reactivation and infection. And so really, this highlights the fact that signaling through the JAK-STAT pathway may be contributing to inflammation and tissue damage in graft versus host disease. Beyond ruxolitinib, there is really no consensus therapy, and most centers will have their own preferred therapies. Some therapies that have been attempted and published are mycophenolate, TNF inhibitors, ATG, extracorporeal photopheresis, sirolimus, mesenchymal stromal cells in addition to others. And these are summarized fairly nicely in this review that I've put down here on the slide if you're interested. Finally, supportive care in acute graft versus host disease is very important. Some ideas here are antifungal prophylaxis. There was a trial back in 2007 showing that patients with steroid refractory acute graft versus host disease who were prophylaxed with posaconazole had a lower risk of invasive aspergillosis and death from fungal infection as compared to fluconazole. Important to know that posaconazole is a strong CYP3A4 inhibitor, and thus you may need to adjust doses of medications such as ruxolitinib for interactions. CMV monitoring and preemptive therapy is very important in these patients when they're on high-dose corticosteroids, and protocols for this tend to be center-specific but cannot be ignored. Another important thing to keep in mind, particularly in acute graft versus host disease of the GI tract, is nutrition support. It's very important to have our dietitian colleagues involved, as these patients can become rapidly malnourished and in more severe cases may need enteral or parenteral nutrition. And that takes us to the end of the presentation. Thank you very much for listening.